So this is the first, this is like a patient with cirrhosis.
Okay.
And so this is the first study that was done, and this is a follow-up study done 3 months later. So I didn't read the study, but one of my hepatology colleagues like ran this by me to let me know, ask me for what I thought. So what was called was all these sort of arterially enhancing scattered foci.
Like SADS, TADS, FIDS,
What
TADS.
do you think? So this was given as a wide differential diagnosis, including metastasis. And this is why my
Well,
colleagues were like, my hepatology colleague was reaching out to me. And so this is
can
exactly
we
what I told them. Yeah.
can we see other phases?
Yes. What do you want
Right.
to see?
Well, I think portal venous phase and
Mhm.
maybe fusion.
Yeah.
What was
Okay.
it done with EVIST?
No, we don't do EVS unless we're doing like adenomas. I mean, FNH or so here's a portal venous.
Hmm. I mean, the wedge shape, the peripheral, mostly because they're wedge shaped,
Mm-hmm.
and they enhance an arterial phase, and then they become iso-intense or iso-tense if you're using CT. It's
Mm-hmm.
pretty classic.
Yeah. Yeah.
But
So
when they're rounded, they can really mimic little lesions.
yeah, and they look scary, right? Because it's like central, there's like non-enhancement, and then so I can see why my colleague called this like, gave like a really broad differential. But I saw this and I'm like, it's just a like thin. Um, and so the patient got a follow-up, and they all got much better. So this is the follow-up, and you see it's just like less pronounced.
Well, it's
So
not
this,
it's not that it got better because look, the phase of imaging is slightly different.
oh, gotcha. So it's just the
That's what it is.
timing.
So you look at this. This one is a little earlier
Yeah,
than the other one. So that's the
yeah, that's
reason.
true.
That's a pitfall because if the second one was the first case, right,
Yeah.
and then the one that you're scrolling through was the follow-up study, you may think, oh my goodness, they grew in
Mm-hmm.
increased size and number, but you have to be
Mm-hmm.
aware that depending on the phase of imaging or the
Mm-hmm.
exact timing of the bolus,
Mm-hmm.
they can be bigger or smaller, So that's another pitfall for them.
That's a really great point, actually. I didn't notice that, but you're right. Because here the portal vein is not enhancing, whereas it's starting to
Right.
enhance as the late arterial, whereas this is an early arterial. But there was no focal abnormality on T2, and it sort of became ISO on portal venous.
Right.
So I told them this is a THID, and that's what it was. So these little dots in the liver can be kind of hard sometimes. So these transient hepatic intensity differences can be there's a lot of different causes. One is like siphoning. For example, if you have like a variant drainage, and the other cause is portal branch compression or infiltration. Also there's a thrombus in it, obstruction, and then you can have flow diversion from arterial portal venous shunting. So there are different causes that lead to these transient hepatic intensity differences, and these are all sort of like what quote unquote perfusional, right? So here's a case from the AGR paper that shows a patient had a biopsy, had developed a cholangitis afterwards, and then there was impaired drainage of the peribiliary epiplexis leading to a THID. So they have segmental and non-segmental variation. Here we have a segmental variation here. This is from a portal vein thrombus that's causing this shunting THID appearance. But the key is they become ISO so that they don't persist and there's no washout, for example, which you would see with, HCC. Here there's a arterial portal venous shunting that's leading to the THID. Here they have this polymorphous hyperenhancement from a drainage anomaly from the right gastric vein. So, various things can cause THID, but knowing that they're segmental, typically they become ISO on portal venous are really critical to make that diagnosis so that we're not
So,
inappropriately directing patients.
right. Another thing to notice is occasionally they, especially in cirrhotic patients, there may
Yeah.
be some signal changes on T2 and
Mm.
diffusion. And then if you are suspecting that you're dealing with a perfusion anomaly,
Yeah.
either because of the shape or whatever, and you need to, EVIS is a great kind of way
Oh, I
to,
see. Just to confirm.
they will be completely iso-intense on
Uh,
hepatobiliary phase.
great point. Great. Excellent point.